So let's talk about safer intubation. I've followed a novel strategy called as the P3 model. Let me know, are the slides moving? Can you see the slide move?
Yeah, moving.
Excellent. Okay, just to be clear. Right, so this is where I'm based. This is our maternity block within the university hospitals, one of the largest employers of NHS in the UK. And the talk about today, I've divided into 4 different sections. The first section is general introduction about what makes intubation a big deal and why is neonatal population we need to be more mindful. What are the physiological effects of intubation, followed by a few adverse effects, but majority of my talk is focused on these interventions in the end, and it's about being practical aspects about how we can make it every event count as a safe event. Right, so looking at neonatal intubations, I'm not going to talk about why do we intubate. I will give a brief introduction, but not more so much about the airway, etc. So the intubation as such, we know that it's a low volume but a high risk procedure. So we're following by the 3 Ps, that's practice, patient, and provider model. So if you look at intubation practices over the last couple of decades, I've given the reference article below that was published just very recently in American Journal of Neonatology, looking at trends of how often are we practicing the skills on the neonatal unit over the last couple of decades. And if you look at practices like umbilical venous cannulation, the practices have always been increasing, and the numbers of umbilical venous cannula has been increasing, whereas arterial lines have been declining. But you would expect that if there are more and more preterm babies being born, and intensive care units are having more and more aggressive strategies at resuscitating babies, then naturally the intubation practices would increase. But also we've seen a trend towards non-invasive ventilation in the last couple of decades, more and more use of, just like how Dr. Suman Rao spoke about use of magnesium sulfate, antenatal steroids. Better preterm care means that we are able to shift towards non-invasive practice soon from birth. And this has led to this graph that shows that there hasn't been much of a change in intubation practices on the in the neonatal population across last 2 decades. Also, we know that if you have a first successful attempt, then you have a better outcome. If not, the outcomes are not so good. The patient's neonatal population as such, if you were to look at all the adverse events that happen within a hospital, the most number of adverse events either related to medication or intervention happen on the neonatal unit, and which is why we need to be more focused about making practices safer on the neonatal unit. And as such, we know that any adverse event of such as intraventricular hemorrhage has got lifetime consequences on the babies. And you have the provider characteristics, that's changes to the training competency. So there's more and more emphasis on preterm non-invasive care, which means we are being slowly de-skilled in intubation. So just a quick review of why we intubate newborns. I think the whole idea behind this slide was to introduce, you might be aware of the neonatal airway registry, the one of its kind in United States, where they have an extensive database about all the the characteristics that feed into intubation. So they looked at multicentric data analysis between 2014 to 17. They found that most intubations actually happen on the neonatal unit more than the delivery room. The most common indications were in the descending order were ventilation failure, followed by oxygenation failure. A few of them were related to frequent apnea and bradycardias. Some of them were sort of semi-elective, pre-procedural, and sometimes because of non-respiratory unstable hemodynamics. And these are very important to bear in mind as to, first, to know why we intubate babies, and second is to how we can make them safer and where it would be to make it safer. What are the physiological effects? That means which are very likely events that happens as a consequence of intubation. So again, I've got a reference here. All the references are in the sections in the last. I'll share that source with you. So the physiological effects are divided into two aspects. One is independent effects, and second is primarily due to laryngoscopy. So the hypoxia that follows intubation is often due to interruption due to continuous oxygenation. And we have seen this study which shows that pre-oxygenating them, adequately pre-oxygenating them, and maintaining continuous uninterrupted oxygenation to the babies has improved outcomes. The second is babies do get bradycardic during intubation, and that's reflects due to vagal stimulation. And the use of anticholinergics such as atropine has shown to prevent these outcomes. That's variable practice between centers. Not everybody routinely use atropine as a pre-medication. Third, the next is catecholamine release that leads to hypertension. It has been shown that rational use of sedation and opioid or muscle relaxant agent can prevent this or can minimize this. There's also an effect on coughing and agitation related to increased intracranial pressure and effects leading on to, especially in vulnerable babies, such as preterm babies with intraventricular hemorrhage. So these are physiological effects. Just a couple more slides on the adverse events. Again, deriving from the evidences, it has shown that there are two forms of adverse events. Fortunately, the incidence is shown to be anywhere between 22 to 39% of the events are adverse events, which is quite high compared to the adverse events that happens in the pediatric population or even in the adult population, or even in pre-hospital stabilization. So if you look at adverse events, you might divide them into non-severe and severe adverse events. So the non-severe are esophageal intubation, but which follows an immediate recognition. The second is oropharyngeal bleeding or some difficult bag and mask ventilation, inadvertent going too deep into the bronchial intubation, or following vomiting or chest wall rigidity, mostly related to use of fentanyl or opioids. The second type of adverse events that I wish to introduce is the severe type of side effects, which have been described to either hypotension requiring inotropic support, or transition to immediate emergency intubation. Third is advanced resuscitation, that's use of either drugs or chest compressions. Next is development of a pneumothorax because of the inadvertent pressures that's been delivered during intubation, or peri-intubation support. Airway trauma and even death, fortunately rare, but these are the sort of severe side effects that have been reported during the adverse events. So just to introduce what's the 3P model to make practice safer. This is widely followed in various other preventative strategies. It's called patient practice provider model, about recognizing the components and how we can target each of these components to make a practice safer. So what are the patient components that add to making intubation a big deal? One is the physiological stability. So aiming to get a safe, understanding what constitutes physiological stability and why it's important is probably the most important aspect of the patient component. The second is understanding that the newborn airway anatomy is different from a child and adult. As we know, I wouldn't dwell too much into it because we are all aware of the differences between newborn and adult airway. And the understanding of this concept, probably spread through message of education, is important to know that we are actually dealing with a separate patient group. The next is provider component. So if you were to look at how do we, the providers are us, the proceduralists, the one who intubate babies. So we need to look at addressing our own competencies and deriving from our own experiences. I will dwell too much more in detail later on after this. So the practice aspects of making intubation safer is looking at standardizing medication, standardizing equipment, deciding on what is the safe location for intubation, is there a definitive location, and looking at few organizational factors. So first of all, the patient characteristic. So we spoke about physiological stability. How can we achieve physiological stability? So it has been shown that use of pre-medication gets you optimal intubatable conditions in babies, which help you to intubate safely. The second is about pre-oxygenation. We are aware of a study by Hodgson et al., which was published in NEJM earlier this year, showed that use of nasal high flow therapy during intubation minimized events, physiological events I spoke earlier, such as bradycardia or desaturations. And the third is use of appropriate monitoring and equipment. You might wish to use carbon dioxide monitoring. You might wish to use continuous saturation monitoring. Of course, being mindful about the temperature, not to lose temperature during attempts at intubation. And third, as I spoke, was greater understanding of airway anatomy to be spread to intubators, especially in the early stage of your career, is to understand why these characteristics are different. The next is to look at provider characteristics. It has been shown, deriving again from this trial that I've shared below, is looking at number of attempts at intubation. So the greater the number of attempts, the poorer are your outcomes. So we need to aim at a successful first pass attempt at intubation. How do we gain that? That's quite difficult because we need to have an adequate seniority. It has been shown that there's a strong relationship between the more senior the person who attempts has got a more successful chance of obtaining a first pass attempt. But of course, whether it's a postgraduate trainee or a consultant, we need to be aiming at having a structure, a standardized way of developing a competency assessment tool. And this article is available from published in Academy of Pediatrics in 2019. I do have this article. And if people wish to source it from me, please do write to me. And it says how we can develop a structured tool to assess someone who is developing an intubation competency. The next is the professional group. There was an argument and debate about who is the best person, because we know by far and by evidence that children and adult population are a separate group, and anesthetists are very skilled at intubating these babies. But when it came to neonatal population, there's always an ongoing discussion that who is the best person to intubate them. It's been shown that an experienced neonatologist is far more safer and gets more likely to obtain an airway than an experienced anesthetist. Right. So next, looking at practice characteristics. So the medication-wise, as I said, there is an overlap between this and the patient characteristics. Is the use of pre-medication. There have been several surveys which have shown the variability in use of muscle relaxants, sedative, and analgesics. The pre-medication drug is quite variable, but all in all, most of them have tend to move towards having a standardized regimen. The most common combination being a sedative analgesic with a muscle relaxant, plus some minus use of a vagolytic. Some places even use a vagolytic such as atropine at the beginning. That's called as an AFST. So A stands for atropine, F fentanyl, S for succinylcholine, and T for tube. We at Stoke-on-Trent, we use FST, and if required A, that's fentanyl first, followed by succinylcholine, and then we tube the baby. And also looking at, do you have a standardized prescription chart, or do you prescribe these drugs on a routine prescription chart? Having a standardized prescription chart avoids various prescribing errors, and hence that's another step towards making practice even more safer. Few quality improvement projects have looked at having a pre-calculated dosing so that you don't spend your time in this time-critical junction in looking at your putting a cognitive overload in calculating the doses. So if you have a weight range, you have a pre-calculated dose of these drugs that's been prescribed. I'll show you an example of this that we have developed at our center. And Project NIC from Southampton, led by Dr. Alok Sharma, have shown an excellent quality improvement project in having pre-prepared pre-medication kits. That means you have a pre-medication kit that's for the weight range, and on an event of an intubation, you just bring in that kit and administer those drugs. So there isn't even an issue with either drawing up and calculating the drugs for the nurses, etc. So these are some of the interventions from medication that can be done to make intubation safer. The next is equipment. So it's always good to have a standardized airway guide within all the units to say which babies, which size, and how far you need to go. I will, again, in my subsequent slides, there's a slide which I can share it with you. Use of video laryngoscopy has been shown. It's an expensive piece of equipment, but it's been shown that it improves intubation safety, and you more likely chances of getting first pass intubation, better understanding of airway anatomy, and if there are any airway pathologies, it has got an early escalation to a difficult airway situation compared to use of standard laryngoscopy. The next aspect of practice, where do we practice, is the location. Preferentially, it's safer done in a controlled environment. So if your baby were to be born, say in your accident and emergency, or your casualty, or in your, by the roadside, or in your car park, or in the corridors of your hospital, then it's safer just to resuscitate them and transfer them to an area of controlled environment where you can intubate them. But now also the practice is moving towards especially the babies over 32 weeks or 1.62 kilos, is to use LMA to obtain a definitive airway initially before you can bring them to the neonatal unit, assess them, and see if there is an ongoing need for invasive ventilatory support, and then you intubate them. So this is an example of pre-medication for the neonatal intubation that we have developed, and it incorporates all the drugs as required, with a very clear prescriptive guidance about how to make the drugs, and how the sequence of using the drugs, etc. The next is using a drug dosing medication. As I said, the weight-based guide. So this also makes it a lot safer, because you have, all that you have to do is, if, for example, if you're intubating a baby of 2.3 kilos, then you follow this particular column and prescribe these drugs along the chart. So there isn't much of a load about remembering the drugs or dosages and calculating them, etc. The one other thing that we found it quite variable in practice is airway equipment, as people, depending on their ability to memorize and remember what equipment is required. So again, we have developed the same thing by the gestational age, what equipment is required and what size that you need to bring in. It's as simple as that. So you just go through this column and say, okay, we are intubating a 26-week baby. Please bring in a 2.5 cis tube. We need to be going as far as between 5.5 to 6 centimeters. We always practice oral intubation. We don't do nasal intubations at our center, and use a 5 French suction catheter. So far, this example, this is just an instance of how standardizing airway equipment can bring about consistency in practice between teams, and that you don't rely on variability. The variability is the thing that causes more and more prone for error. Having a timeout guide, just like how you have a WHO checklist for pre-operative checklist, we do have this sort of across United States, they call us timeout guides, but we do have, in UK, we call them as LOCSIPs, or local safety standards for procedures. And this is one of such that we use for intubation. So this prior to the intubation procedure, the person is assigned to go through them and ticks them, and everyone stops and pauses, and we follow this checklist to ensure that all the steps are completed. And this has again shown to reduce incidents related to patient safety. So the system characteristics, this is very important. Looking at the broader picture, intubation is not just purely down to the provider or the patient alone, but there are various other things that we need to address. Is how is the microsystem in your unit that you're working? How is the team working? How is the communication? How are the human factors? And what is the sort of workflow that you have? What kind of handover culture do you have? How is the handover practices? How do you hand over patients with difficult airway, etc.? And what sort of safety culture, in the sense, how do you recognize events? How do you address events? How do you highlight safety events? And what sort of a responsive culture that you have towards addressing a previous adverse event in making the future practices safer? And these are extremely important in defining the culture of a unit. The next you have is what sort of training opportunities are available. How do you deliver training to your subsequent groups coming on to ensure, and are there any staffing challenges that's impairing delivery of training, etc. So that those are the other issues that needs to be looked into. Again, I spoke about the safety culture. What we need is a growth mindset that, yes, we have made a mistake one time, but we learn from it. We learn and make the practice safer the next time. And this is something that's very, very specific to your local unit. And we have to show that we will be able to do a risk assessment, and as well as, have a safe handover technique, but both between medical teams and nursing team. And we follow safe practices. So are there any evidences that's put together and shown how we can reduce adverse events? So this particular study from Pediatrics in 2016 made a bundle, a QI bundle, showed that use of a timeout tool that I showed earlier, having a pre-medication algorithm and a computerized provider order set to source the drugs and dispense the drugs, reduce the adverse events drastically from 46 to 36%. And there was a temporal relationship in developing a timeout tool. So if you were to say, is there one tool that we can develop to reduce or to make practice safer, is to develop your own timeout tool. And it's not specific to any health systems. It can be used widely, just like we have WHO checklists. If anyone wish to borrow mine, please do write to me. I can send it across to you. The next is, how do we put this all together? So just to summarize my talk, I hope I'm keeping to time, is developing your own timeout tool. One, developing your own guidelines. Do you have a guideline for intubation? Do you have a guideline for escalating to difficult airway? How do you seek senior presence? Is there a proper escalation management within your unit? Having your own prescribed prescription chart, and following as much delivering your education through translation simulation. That's found, it's a skill that's decreasing in its frequency of usage. Translational simulation is the only way forward to ensure that we provide adequate training to the subsequent batches. So that was a brief talk. We are located here in central mid England. We're right placed between Manchester, Birmingham, and Liverpool in the epicenter. We've long history to account for from the area of Staffordshire. So you are please welcome. We do have an international training fellowship opportunity. So if anyone's interested and coming to end of your postgraduate training or in early career, please do write to us. We can look at opportunities for you to work here for us. So any questions? Here's a QR code. Feel free to point your mobile phones. It will bring you to a list of resources, which I shared earlier. Some of them are actually very useful. It's a combination of articles and YouTube videos, which shows how intubation has been made safer in various places, and including the reference articles. They've all been included in this list of resources through the QR code. But if you have any difficulty in viewing the QR code, either because of your the connectivity or mobile phones, please do write to me and ask whatever resource you need. If you need my timeout tool, I'm very happy to share. Excellent. Any questions?
Thank you, sir, for an excellent lecture. Usually this intubation is usually not talked of. They talk of so many newborn problems, but we are very happy that you took up this topic and you have discussed in detail. So I have a question for you.
Sure.
I'm Rathinasamy, one of the professors here, and our HOD is also here, Dr. Rajakumar. We had a case of Peri-Robin syndrome with some laryngeal problems. We intubated and we had to keep that intubation for 3 weeks. After that, the child needed tracheostomy, which went on for 9 months or 10 months. And we closed the tracheostomy at 10 months. Now the child is 2 years and doing well. So how long maximum you have kept the intubation, ET tube in situ? How long maximum we can keep in a full-term baby?
So it depends on the reason. So we do attempt at, if you are failing at frequent intubation, then we need to be looking at what is the cause for intubation, the airway dependency, especially in a term baby. If their ventilator pressures are dropping and their oxygen requirement is dropping, then we do take every attempt at extubating them. And if there is a reason for frequent extubation failures, then in preterm population, there is a definition for extubation failure. We say the need for reintubating within 48 hours after extubation is an extubation failure. But in term, we do expect them that once they reach the extubation threshold, they would sustain spontaneous breathing with or without assisted pressures. So it would be unusual to go back onto needing intubation need. So the answer depends on what's the reason for them being ventilator dependency, is how long we can keep them. We do transition some of the, such as the one you've described now, the ones with the difficult airway anatomy or lung pathologies, we keep them intubated until we're able to transition them to sort of finding out the definitive pathology, rectifying them, and then potentially looking and transitioning them to home with a possible CPAP or a BiPAP, which may or may not be without a airway, such as your tracheostomy. Does that answer? Sorry.
Thank you.
Yeah.
Sir, I'm Dr. Sundam, postgraduate from here. Recently, we read a journal that nasal high flow oxygen is being used during intubation for the positive outcomes. So, are you using that technique over there?
Yes. Yes.
Please kindly share your opinion.
Yes, definitely. I think that's been a biggest. That was a fantastic article this year that came out, isn't it? Earlier in the year, I've shared that reference in the article about how to make it safer is ensuring continuous uninterrupted oxygenation during intubation. Because what happens is we tend to pre-oxygenate them and take away the face mask and then attempt at intubation. The duration of intubation varies, so the more experienced people might get it within first few seconds. But most of us, some of us might take longer. So this interruption of oxygenation for a baby who actually needs it the most should be minimized. And use of high flow, continuous high flow during intubation has been shown to minimize the physiological effects of hypoxia and bradycardia. So I would definitely strongly advise, to shift towards a high flow support. Some have said that we use continuous CPAP during intubation, but the thing about CPAP is sometimes the CPAP interface in front of the nose itself might be so big that you may not be able to get an adequate view. And such as the equipment that we use in our unit, we've had issues with that. So not just for intubation, even for LISA, we switch over to high flow during the LISA procedure and then switch back to the support. I know it results in increasing use of consumables, but if it makes it anything safer, we can't place a price for the life. So we do switch over to high flow support. The other thing about CPAP versus high flow is CPAP is very much dependent on seal. So you know that when you open up the mouth and trying to intubate, you lose that seal, so it may not be as effective, but some form of continuous oxygenation is definitely recommended. I haven't been monitoring the chat.
Rajakumar has one question, sir, and he will give the concluding remarks in this session.
Yes, sir, I'm Dr. Rajakumar, HOD of Pediatrics. I have a question that you have shown the chart of pre-medication. Is it available there? Or?
This chart?
Next one, sir.
This one?
Yeah, this one.
Yeah, I'm happy. I have developed this, so I can share it with you. If you please share me your email, then I can write it out to you. Yes. Or I've left my email in the front slide, so please write to me. I'm very happy to share them with you.
Because these help in calculating at that moment how much of drug to be given.
That's right. Yes.
This is a very useful chart, sir. Very nice.
No problem. No problem. There's actually one more. I don't think I've shared it with you. Let me find it, because that also has been found to be really useful in having a flow chart about how you go through the process. Unfortunately, I think it got lost somewhere. Whilst I'm looking for it, if there are any other questions, I can take them.
So one more question, sir.
Yeah.
How many percentage of newborn will
require ventilation in your area? Because is it
So-
the incidence of asphyxia is very high or less? And what is the percentage like?
Sorry, I missed the last part of the question.
Incidence of asphyxia is very high there or low?
It is. We do have quite a few, birth insults that come out, mostly in term babies. But we do have occasional preterm baby which come out with hypoxic ischemic insult. If that's the answer, it's not completely zero. That's still a big patient safety issue. And if you have seen in the high-profile media, we've had few maternity safety investigations across various centers looking at how we can optimize our maternity centers, how we can reduce safety issues, which has led from certain high-profile cases. So what's the incidence of intubation? I think it varies. Almost all babies born under 24 weeks do get intubated. We don't try non-invasive support because we know that chances of intubation failure is very high in this population. But in babies over 24, 25 weeks, and if they've had antenatal steroids and if they've had magnesium sulfate, we know that they're very likely to, we do give them a chance to see if they can sustain without invasive support. So from delivery room, we try and maintain them on non-invasive support, bring them to the unit. I would say still about 2/3 to 3/4 of them do still require intubation within a day or two. But even the early hours, if you can prevent them intubation, which is when the predominant lung damage occurs, and that's still a good care that you are provided. As much as you can delay in a controlled environment. Almost, term intubation, you have to warrant it. You have to demand intubation. Otherwise, we don't, we almost always manage in non-invasive support.
Thank you, sir.
No problem. Yeah, I'm trying to find that. Okay. Am I allowed to share one more content? I just wanted to show you this to you as well. Let me see if this comes up. Sorry. Sorry. Just see if this. Yes, so this one. Do you see the process chart?
No, sir.
No. Okay, just a minute. Sorry. Now?
Yes, sir.
Yeah, so this is something that we have also done that's helped greatly with understanding the process about where we are and how to go through the checklist, and even for cross personal working, such as if you're working in a team of 3 or 4 people with 1 or 2 nurses and a trainer and a trainee, etc. It's helped a lot in understanding where we are. So we look at 3 branches. One is optimizing the medication. We get the equipment ready and the personnel. So when it comes to medication, does the child have a known hyperkalemia or a neuromuscular disorder? If you do, then we use rocuronium. If you don't, if there is no we check the potassium before, if it's available, or if it's a known neuromuscular disorder. Predominantly, if you're doing for the first time, you wouldn't know it, then probably you go for fentanyl, suxamethonium, and atropine. Then you have these drugs. Atropine is only drawn up and not given. You also keep naloxone handy, but you don't give naloxone routine until you recognize. And so then you administer only fentanyl and the muscle relaxant, depending on what is safer for the baby. Then you insert the tube, confirm the tube, fix the tube, connect to ventilator. Then you document in the notes, communicate to parents. So that's the flow chart. With regards to equipment, we always gather the necessary equipment. We have an equipment airway trolley. So it's all easy to find in one place. We just draw the trolley to the side. Then we go through the LOCSIT, that's the timeout tool, and then follows by this process. We don't go to this process unless all this is complete. And with regards to personnel, you identify always a team leader who is going to be the leader. It doesn't necessarily has to be the person who is intubating. It can be someone who is standing behind, like a helicopter view, and guides the team about where we are in the process. There should be a proper allocation of roles and responsibilities. So we always say that person who intubates knows other people by name and addresses them by name, because that cuts short your human factors again. Then, of course, in the era of the COVID, we had to follow the PPE and safe distancing rules as far as possible, and then we go through. There is an order of administration. First, fentanyl, slow IV over 60 seconds, because most of the safety events related to fentanyl were due to rapid administration. So this is the check we have followed, and giving slow administration of IV, followed by a slow flush again to prevent chest wall rigidity. The next, followed by succinylmethonium rocuronium. And we have a small troubleshooting guide also. And this is a part of our prescription chart. So this is the first page of our prescription chart. The second is actually the prescribing area. The third is our airway guide. And fourth page is the log set. So putting this all together is a single unified document. Troubleshooting is, how do you anticipate and plan? Are you going to anticipate a difficult airway? Do you need more help? Then what do you do if there is suspecting fentanyl overdose? What do you do if you suspect a chest wall rigidity? What do you do if you have a bradycardia after intubation or giving muscle relaxant? So these sort of things have helped us to make a safe intubation chart, but that's one amongst the several interventions that you can use, but this is found to be extremely useful again.
Hello, sir. This is Dr. Ajay Prakash, resident here.
Hi.
So what is the incidence of chest wall rigidity following fentanyl? How can we avoid, apart from the slow flushing?
Yeah, so that's a really good question, because we've had a lot of debate about the reluctance to move from morphine, which used to be our standard drug, to fentanyl, because fentanyl provides you the optimal intubating conditions, but there is a constant fear of opioid-induced chest wall rigidity, of which fentanyl is a notorious agent. What research has shown, what practices have shown, is that the chest wall rigidity related to fentanyl is more due to rapid administration. So to be very slow in administering fentanyl and also giving the flush followed by it has shown to greatly minimize chest wall rigidity from fentanyl. No problem.
So thank you so much for the presentation, sir. We'd love for us to have a copy of that presentation, so we can reference
Yeah,
it.
sure. Yeah, I'll share it with you. If you need any more documents or anything, please let me know.
We will, sir. Thank you, sir. Thank you so much.
Okay, nice interacting with you all. Thank you so much for this opportunity today.
Thank you.
Take care. Bye. Bye.